we can diagnose CCSVI, but while you're having that procedure done, it doesn't allow us to treat at the same setting. Venography, catheter venography does. Catheter venography involves putting a catheter or a tube, and you can look at them, and I would actually invite all of you to take a look at some of the tools so you can get a feeling for how small these things are that are over on the table on the side there. Patients have to be well hydrated. We get their fluid level as high as possible before we do the procedure. Again, we use ultrasound guidance and minimally invasive micropuncture systems to make access to the veins, so they're very safe. There's been a lot of discussion of whether we should go in through the right common femoral vein, on the right side of the thigh versus the left side of the thigh. There was a lot of discussion early on about how accessing the left vein was necessary because we might miss problems with what's called the May-Turner syndrome or abnormal flow in the veins at that level. What a lot of us have found, Gary Siskin and I have talked a fair amount about this, is that the likelihood of problems with those veins down at that level, the iliac veins in patients with CCSVI, is essentially the same as it is in patients who don't have CCSVI. So basically what you're doing is making the procedure a little riskier for patients, a little technically more difficult for no real benefit to go in on the left side versus the right side. That's why most of us now use the right side to make access. We do use conscious sedation. That's what used to be called twilight sleep. That's really just so that we take the edge off. I think this procedure could be done with local anesthesia, but I personally would rather have it done with conscious sedation, so I think it's the right way to do it. It also allows patients to sort of change their position as we ask them to, take deep breaths, and allows us to get the images that we need to get. Catheter venography allows us to define grades of abnormality in the veins with the catheter venogram. Grade 0 is normal, so that's not up here. Grade 1 is venous outflow slowed down. No reflux, but the flow isn't going as fast as it should out of the vein. Grade 2 is slow flow with mild flow in the wrong direction. So instead of the flow all heading down toward the heart, some of the flow goes back up toward the brain, and it may or may not have some dilatation or increase in size of the vein just above the area of narrowing. Grade 3 is the venous outflow is slowed, and we're starting to see these detour blood vessels, collaterals. And grade 4 is no outflow. None of the flow goes through the jugular vein the way it should. It all goes through these collateral veins. And this is an example of each of those grades. You can see here, this is obviously it's easy for me to tell you this is no flow because the images are sitting still. But if you're looking at the real-time images here, you'd see that the flow in the jugular vein basically sits still for more than one heartbeat for each of the levels of the vein. And that's how we define no flow. If you look at this vein, you see that not only is there a narrowing, but there's also an area that gets wider right above the narrowing, so that's the prestenotic dilatation that we're talking about. And then if you look at the third level, we have narrowing, dilatation above the narrowing, and then flow is starting to sneak out through these collateral channels. And finally, the highest grade is when there's no flow through the jugular vein, but there's flow through the collateral or detour pathways to get through to escape the nervous system. This is just an example of what someone looks like with grade 3 flow pre and post procedure. So you see the area of narrowing at the level of one of these funnel-shaped valves, a little bit of prestenotic dilatation. This is the angioplasty balloon being dilated, and if you're sitting close enough, you can probably see there's a little bit of a waist or narrowing right at the level where that area of the valve annulus is located, and it's about to be cracked. And then this image shows what it looks like after that area has been dilated successfully. The flow is now passing through the vein the way it should. So the procedure has risks, and they can be divided into two different categories. There's the access in venography. This is sort of the diagnostic part of the procedure. And then once that part's done, the risk of the angioplasty. The risk of the access in venography is really very limited and essentially involves bruising or bleeding at the groin level. It's very unlikely because, as I said, these tools that we use are designed for this purpose and very, very small. The other risks include reactions, any type of allergic reactions. We've talked a little bit about arrhythmias. This is when we have to go through that. In the United States, we have these things in the highway system called rotaries. You guys have seen those where, a bunch of highways come together in one area and then they all go back out again from the same. Well, the heart acts that way. All the veins come together like a highway coming to the heart. And so, if you can get into one vein, you can pretty much get to any other vein throughout the rest of the body. But as you go through the heart, you have to watch the rhythm because you can change the rhythm of the heart with your catheters and wires. Angioplasty carries its own set of risks. As I said, the goal of angioplasty is a controlled injury to the vein. And so, depending on how much you need to dilate that vein, you are going to have to tear the lining of the vein at least to get it to open up to the level you want it to open up to. But the goal is to damage the vein in a controlled fashion and not damage the outside of the vein, or what we call the adventitia of the vein. And there are things that we do to make it so that doesn't happen. There is a risk of blood clots, and as I was telling somebody earlier before we started, I think that the risk of blood clots in the jugular vein is higher than people have talked about. And that's not just based on our experience with CCSVI, but what we've seen in other parts of the body. I personally think that number is probably between 5 and 10%. I think that people, when you do a dilatation, of the vein and damage the intima or the lining of the vein, I think it's very difficult not to have some clot formation. It doesn't mean that the procedure shouldn't be done this way, but I think that you have to protect against that clot formation by anticoagulating patients for as long as you think is necessary to decrease the risk of major clot formation. I put down here failure to respond because it's not really a risk of the procedure, but when I go into these procedures, every patient that I talk to, I tell them, they're really safe procedures if done appropriately. And I think the risk is so low that the biggest problem, the biggest risk of the procedure is that we don't get the response we want. And I think the patients really need to go into this and have their expectations equal or match my expectations in the sense that, I'd love to have patients who are immobile be able to get off the angiographic table and dance around the room with me. But it would be completely incorrect for me not to tell them that, the best benefit I might give you is that you don't progress as fast or that the curve of your progression slows. If patients expect otherwise, then the procedure's failed. Then it's been a risk that I really shouldn't have been there. And if I tell patients about it up front, I think this risk is minimized. So, risk might be the wrong way to describe it, but that's how I feel about it. As far as the procedure, we've talked about access, we've talked about anticoagulation. We thin your blood during these procedures. Whenever you have a foreign body in your bloodstream, you're at risk for blood clots. So we give you blood thinners during the procedure. The balloon dilatation, I would say that most patients are aware of the fact that the balloon is being dilated. You can talk to I'm sure most of you can turn to your right or to your left, and someone who's had the procedure will tell you whether or not they could feel it. But the fact of the matter is it's a minor sensation that we can control with a lot of our medications. There are things we do in situations where we can't make that little waste that I showed you go away. And the most important thing we consider is whether or not we need to use a stent. And in most cases, we will not use stents. We only tend to use stents, and I'll show you on the next slide, in situations where we think it's the only thing left at our disposal to protect the patient's life, limb, or a vein that looked better to begin with than it does when we finish. Things that we do relatively frequently, I think, are adjunctive measures that other people have called cutting balloons. Cutting balloons really can't be used in this location. People talk about using cutting balloons, but frankly, none of the cutting balloons that are available on the market today, either in Europe or the United States, are large enough to cut these areas. The cutting balloons that are available measure 7 millimeters. That's the largest diameter cutting balloon that's available. And a cutting balloon is, I'll show you a picture of a balloon, but it's a balloon with basically a little razor blade or a wire along the side, kind of glued to the balloon. So when the balloon is dilated, those little cutting areas are called myotomes. They cut into the lining of the vein that you're dilating the balloon into. But if you can picture what I'm saying, we're talking about veins that are about, 10 millimeters, 12 millimeters, 16 millimeters across, and you're dilating a 7 millimeter balloon in that vein. You really can't cut the valve in those veins unless the balloon is close to the size of the vein that you're trying to dilate. The way we've gotten around that is by basically creating a facsimile of cutting balloons with a wire alongside the balloon. So I call it wire valvuloplasty. Other people call it different things. And this is a technique that we've used in other parts of the body, so I don't take any credit for it. It's just something that we use. You can place a wire alongside the balloon, dilate the balloon with the wire in position, and the balloon pushes the wire into the wall of the vein and scores the vein where the wire is located, and then rotate it so that it scores it on the opposite side. And now that you've done that, you can do a controlled dilatation of the vein without oversizing the balloon and damaging the outside of the vein. So that's what you hear about when you hear about cutting balloons. That's really what people are talking about. Stents, as I said, very, very little use. In our practice, it's between 1% and 3%. Stents really in our situation, and I think most people agree now, should be reserved for patients who there's a threat to life or limb, or in a patient who's a reintervention. Sometimes in patients who are reinterventions who have a tight scarred narrowing from a prior angioplasty, there's no way you can get the balloon to dilate that area without putting a stent in place. And I'll give you our actual numbers later on, but the numbers are very low. These are the tools that we have at our disposal. This is how we do CCSVI treatment. In the center here, you see the C-arm. You hear about the C-arm. This is our fluoroscopic generator. This is what gives us our screen image so that we can look at it and create digital images. This is the insufflator or the inflator. It's capable of generating extremely high pressures, 30 atmospheres. And what that means to you, what that means is that if you held a balloon that was dilated to that degree of pressure, it would feel like a rock, like a diamond. To me, it means that basically you have enough pressure so that it's the same as if you were 30 stories underneath the surface of the water. That's how much pressure we're talking about. It's a high amount of pressure, so it's no wonder patients feel it a little bit. These are the catheters that we use. They're all different shapes, and they're designed specifically to get to different areas of the venous anatomy. Here are the balloons that we're talking about, all different sizes and lengths. And then finally the stents, the dreaded stents. This is an actual image of the one stent on the market that is approved for venous use. It's called the wall stent endovenous prosthesis. Unfortunately, it's not the stent that anybody uses in veins. We use all the other stents that are available to us because they work better, but that's the one that has FDA approval. So there is one out there that has vein stent approval, and it has for a long, long time. As far as recovery is concerned, when you complete the procedure, which takes between 1 hour and 2 hours, you go into our recovery area. One of our nurses removes the IV or sheath from your groin. That's the point where we'll have you lay still on your back for about 2 hours, and then your family members and friends will be able to come in and wait with you until we're ready to let you leave the area. So just a little bit of specifics about the Rhode Island Vascular Institute experience. Rhode Island's a beautiful place. Anybody who's been down there should be hopefully able to tell you this. It's called the Ocean State because we have about 400 miles of coastline. Beautiful coastline. Some of that coastline is a river walk in the Newport area. These things are summer cottages, really beautiful summer cottages from the days of the Vanderbilts. None of them have heating, which is mind-boggling to me. None of these things have any kind of heating or air conditioning. And they're like, you know, the largest structures you'll ever see, but they're really worth checking out. They're all museums now. Rhode Island has a very beautiful river walk with a water fire, depending on what time of the year you go there. And they have I've heard rumors that there's a lot of Canadian shoppers. There's a really great outlet just north of us called the Rentham Outlets. They do have good stuff there, I'll admit that. Although my wife is the one to ask about the real. Rhode Island Vascular Institute's a 5,600 square foot registered and accredited physicians ambulatory surgery center. We have 2 dedicated angiography suites, which are lead-lined and designed specifically for angiographic procedures. We've existed since 2005. We opened our door in 2006, and these images are from 2007. So, you know, we've been doing this stuff in our facility long before CCSVI came around. We have a 6-bay pre-op and recovery area, and this is some of the smiling staff who many of you have either interacted with or spoken to on the phone. Really, I mean, it's an amazing staff that we have the pleasure and the privilege to work with. These are great people. I'd have them take care of any family member. Who are our patients? 75% of our patients are Canadian. We're CCSVI patients. That's a mind-boggling number if you think about it. We've treated close to 500 patients. So you can do the math. As far as who we treat, patients have to have a confirmed diagnosis of multiple sclerosis at this point. I understand fully that CCSVI is being connected to a lot of neurodegenerative processes, to chronic fatigue syndrome, to Lyme disease, to Parkinson's disease, ALS. We're still at the point where we feel like we should restrict this to patients who have multiple sclerosis, and we're still doing so. We do treat patients in all stages of debility, so not just relapsing remitting, although we do think that patients with relapsing remitting form of MS are getting the best response. That's what people across the board are finding. We are starting to see an upsurge in patient interest in the United States, and I think that's wonderful because finally, I mean, you know, there are 350,000 patients in the U.S. with MS versus 80,000 or so in Canada. So it's about time that people start realizing there's something else out there for them in the U.S. We'll see if that continues. A lot of that depends on Obamacare. Who will we not treat? Well, if a patient doesn't have a diagnosis of MS, as I said, they're not going to be considered. If a patient